Good morning, everyone. We are up and running. Welcome to another of Claremont's regular webinars where we do a deep dive into behavioural change themes. I'm Tim Parry, I'm a director here at Claremont. So today we are looking at safety campaigns and interventions, and we're asking ourselves, what can we learn from work in the public health sphere to help evolve and improve our work in safety? And we're talking about safety and around. So today you're going to hear references to all sorts of sectors or subsectors within safety. So that includes road safety and water safety, violence reduction, civil safety, fire safety. We're really looking at it in quite a broad way. Now, you might not have heard anything about the idea of using public health thinking for safety, or you may be a seasoned practitioner. You're all welcome. And we have attendees today from emergency services, a range of public sector safety teams, organisations, charities, local authorities, academics, friends, partners. You're all really welcome here this morning. So what we thought we'd do is offer a simple framework to help provide a kind of way into this world. And in a moment, my colleague Mikaela is going to spend a few minutes offering that introduction to us all with lots of examples from both public health work and from safety for some inspiration. And then after Mikaela, we're going to spend the remainder of our snappy 1 hour view this morning with our assembled panel of experts to explore the theme further. We've got an amazing group bringing their perspectives today. That includes Senior Academic from Bournemouth University, Dr. Jill Nash. We've got the Road Safety Trust Director of Comms, Paul Steinberg. Research and Data Science Director, Tori Ulfin, MBE. We've got Claremont's founder and behavioural change practitioner, Ben Caspers, and social researcher and behavioural change consultant, Dr. Simon Christmas. Really amazing panel. Grateful to all of them for joining. So we're going to hand over to Mikaela in a second. She's fired up her deck ready to talk to you. But whilst we get that ready to go, can I draw everyone's attention to the chat function on Teams, where we invite you to introduce yourselves and to connect to each other. And throughout today, you can use that chat function and the Q&A function to ask questions for our panel discussion, which is coming up a bit later. And we'll do our best to respond to as many of those as we can this morning. Also, we have an exciting new innovation for these events because we've got a short Teams poll coming up at the end of the session. It's only 3 questions. It'll take you 2 minutes, but if you can respond to that, I'll be super grateful because it helps us to plan future events to improve things and give you what's useful for these sessions. Okay, let's get cracking. And I'm going to pass over to my colleague, Mikaela Green, who's a senior consultant here at Claremont. There she is. And you're going to set the scene for us, Mikaela. Over to you. Thank you.
Yeah, thanks, Tim. I've got a very busy 15 minutes to talk to you about how to apply public health principles to safety challenges. So I'm just going to get on with it. And I wanted to start by sharing this with you. We call this the SAFER model. We wanted to provide something tangible for you to take away from today's session. So we developed this little acronym mnemonic tool situation, which you can see here. And this breaks down 5 things which we think public health interventions and campaigns are doing well. And we or you might want to borrow from these when considering how to make effective safety interventions. So I'm going to briefly read the screen here. S stands for system-wide approach. Well, what does that mean? It means we need to consider environments, consider that there's always a wider context to human behaviour, what systems are at play that we might be able to change or we might be able to influence. A stands for addressing root causes. So this is really about focusing on the social determinants, underlying factors that cause a behaviour, not just looking at symptoms, not just looking at the behaviour itself. Form partnerships, fairly self-explanatory, but this is really working across sectors with schools, police, health, maybe with community partners to have a collective impact. E stands for evidence and evaluation. We had to double these up or it spelled SAFER, which wasn't as good. This is a bit chicken and egg, but this really means we need to base our actions on good evidence. We need to measure and evaluate impact, and we need to adapt campaign plans accordingly. And then finally, representation. So this is really around designing inclusively so that we don't marginalise or worse, exclude any underserved communities. It's not brain surgery, it's public health, it's kind of surgery, but we think it works. And I'll be taking you through some examples of each of these areas and how Claremont and a few others internationally have used these principles in various safety interventions to achieve positive results. So I'm going to start just by talking to you about system-wide approaches. This, I think, is a really great public health example. You might have seen this. It's called How Are You? It's an initiative launched by the government in Ukraine from the Ministry of Health. Since the onset of war a few years ago, obviously there's been a very big impact on people's lives in Ukraine, particularly around their mental health. So this was a centralized campaign, and it really encouraged people to talk about their mental health, particularly with their family doctor. And the efforts to sort of leverage the wider system or to take a system-wide approach were really considerable. As you can see here, many parts of the system were engaged. So the Office of the First Lady in Ukraine, she really launched and championed the campaign. There were various government departments involved, particularly Department of Education. A coordination centre for mental health was set up to oversee all the operational stuff around this campaign. And there were various international partners, UNICEF, USAID being the big ones. And then there were some private sector tech partners as well, who were creating CBT and other mental health digital tools. So I think this is a really great example of a public health campaign that really leveraged the whole system to make it work. And this kind of system-wide principle was really important for us in some work that we did with the Thames Valley Violence Prevention Partnership, which I'm kind of presenting as a safety example here. This was aimed at young people in the region, and it was looking at how to de-escalate situations where violence might occur. One of the core insights, just to summarize our research, was the need to encourage young people to kind of lean into and trust their sensible instincts, which young people often have in these violent situations, but they need permission to act upon. And we felt this permission could be developed through role models in young people's lives. So part of this system-wide approach is really identifying these role models, looking at the whole system of organizations that surround young people. And you can see some of them we identified on the screen. And it was really about enabling these organizations to reach young people and to empower them with a message, which we ended up calling Stay True to You. And the obvious organizations here would obviously have been youth clubs, but we mapped the world around young people and we found sports clubs, social clubs, schools, teachers, parents. They all had a role to play in building this kind of resilience within young people and enabling them to make safer decisions. So we designed a campaign and we designed resources for these various parties. We helped them to understand the role that they could play in young people's lives, and we made sure they had the right tools to play that role. So Stay True to You became a training program in the end developed by the Blinken Seller Trust to further support practitioners with this approach. I think above all with this one, it emphasised to us that we can't kind of enforce our way out of this problem always, and we have to get ahead of it. We have to look across the whole system and think, where can we best influence the lives of young people for the better? And I'm going to move on now, talking to you about addressing root causes. So just as a reminder, this is looking at the social determinants, the underlying factors which might be contributing to a problem. Claremont worked with the North Central London Cancer Alliance, hello if they're on this call, and they asked, how can we encourage people experiencing homelessness to attend cancer screenings? Obviously a really interesting problem. And we spoke to about 20 or so, 25 people in the area in face-to-face focus groups and co-design groups. And we used a COM-B analysis shown here. Some of you will be familiar with COM-B. It's a behavioural science model to break down what we were hearing. What we heard was that there were far more reasons or root causes to not attend cancer screenings than we found in the general population. So things like fatalism, fear, these are still barriers, but we have to consider other root causes like the difficulty of people retaining and understanding information, the use of medical jargon, for example. And we also understood that these communities were not seeing themselves echoed in any cancer communications. They weren't hearing from support workers or people they trusted, and they largely did not trust unknown medical professionals. And we've seen this working with these populations in the past. They've often been stigmatized by the medical community, and they're not interested in hearing from them. So the root causes for not attending these screenings were numerous, and they were far beyond kind of a person having a more chaotic lifestyle. And this really informed our approach to the interventions. And this is an example of how this has been applied in a safety project. So we're currently working with a large housing association, and we're addressing why tenants might be disconnecting their smoke alarms, or actually smoke detectors. I'm not supposed to say smoke alarms. This is particularly in multi-occupancy buildings where lots of people might be put at risk by this behaviour. Again, we had a kind of assumption going into this. A lot of people said, well, tenants are probably disconnecting their smoke detectors because they're just smoking in their properties. And while this might be true in some cases, we decided to survey residents, and we spoke to many people with professional experience on this issue. And we found actually the causes were numerous. It was much more than that. And we were very careful in this survey, and we used something called projective questioning. So this is kind of asking people about their neighbours and other people rather than asking about themselves, so that we could attract a level of honesty and avoid, I guess, any sort of performative bias in the question answering. And you can see some of the responses on the slide here. So the root causes of disconnecting a smoke detector were numerous. People were bothered by the alarm going off while they cooked. Others weren't able to change the batteries themselves. It was easier just to disconnect the detector. Other people didn't know how to change the battery. They told us that batteries just weren't affordable for them. And this is an ongoing project, but understanding the root causes of this behaviour has really taken us away from traditional fire safety comms, which often use shock tactics, and towards kind of addressing these underlying causes. Why might somebody disconnect their alarm? If anyone's got any comments or questions on shock tactics, I know the panel are quite keen to talk about that as well. And so I did tell you this would be quite whizzy, but I'm going to go into forming partnerships next. So this is a public health example. We worked with a cancer alliance in North East London to understand the white other population, which I'll explain in a second, and their barriers to attending cancer screening. So just to explain briefly, white other refers to a diverse group in the census who identify themselves as any other white background. And you can see a kind of part of the census in the top left of the screen there. So in North East London, this includes high numbers of white Romanians, other Eastern Europeans, as well as Jewish, Turkish, Irish, and many other residents. Their uptake in terms of cancer screening is often not good. And we work to identify and prioritise these groups based on the project's objectives, but the bulk of this work was really sourcing and engaging with community partners so that we could access these populations, so that we could have constructive conversations about cancer prevention. And we work with various partners here. You can see on the screen there, that's the Turkish Cypriot Women's Project, who are brilliant. And we work with a group called HOPEC, who are the House of Polish and European Community. And we really had to meet people where they were. So this was about attending existing sessions in public libraries, community centres, often relying on our partners to support with facilitating these sessions, sometimes translating in these sessions live. And without forming these partnerships, we would have really struggled to understand the people behind the census. So we thought that was a good example of how to form partnerships effectively. And this is an example in the safety world in the same vein. We worked with the National Police Chiefs Council, the NPCC, and hello to anyone on the call from there, to help keep motorcyclists safe on the roads. Some of you will know that an average of 6 motorcyclists die every week in the UK, which is obviously pretty horrifying. The end result of this work was something called Ridecraft, which was a national and co-designed campaign, which you can see on the screen here. And there were a lot of interviews, lit reviews, campaign reviews, psychology, all of that good stuff that went into this output. But it really wouldn't have been possible to build and to leverage this work in the same way without partners. And for Ridecraft, that included the Thames Valley Police, Dot Bike, Bike and National Motorcycle News, all really valuable in pushing this out. I think partnerships can be particularly valuable when you've got a smaller media budget. And the future potential of this idea really rests on further partnerships. Particularly, we're looking at those that are part of riders' world, so kit and bike manufacturers, retailers, cafes, other meeting points where motorcyclists might meet each other. So please stay tuned. Hopefully there'll be some more partnership work to share with you on that one. I'll move now into evidence and evaluation. They're obviously quite tied up with each other, a bit of an entanglement. Can be quite scary, I think, evaluation sometimes. And it can be really tricky, particularly in public health and safety campaigns, to evaluate because sometimes the outcomes are seen well after the end of the project or the intervention. But I wanted to share a really brilliant example here from the World Health Organization and their tobacco-free initiative, which is, exactly what it sounds like. And this covers quite a few different types of evaluation, which might be useful for you to think about when thinking about how to evaluate your safety campaigns. So first of all, they conducted a formative evaluation, and this is really just kind of gathering baseline data to inform what you're going to do next. And you can see in green in italics there the type of evidence that you might want to collect to do something like that. They then carried out a process evaluation. This really looks at, is the intervention doing what it should in the right order? It tracks the fidelity of the interventions. For example, are smoking bans actually being followed? Do we need to stop and change anything about our campaign or our intervention? Then they conducted an impact evaluation. So this assesses the immediate effects of the intervention. So it might be changes in smoking behaviours, it might be exposure to some of the tobacco-free messaging. And then down the road, they conducted an outcome evaluation. So this looks at the long-term effects, the overall success of the programme. The evidence here is a lot of population health data, and they might look at things like have smoking-related diseases reduced, have mortality rates reduced amongst populations that they're targeting. So I think it's a really good example of how you can do an evaluation in different ways and at different stages throughout a campaign. And I think it's possible, and it's really important to build in proper evaluation even on smaller scale campaigns. And I think a good safety example is some work that we're currently doing with the Canal and River Trust. And this is looking at the behaviour of young people around canals, rivers, reservoirs, and other waterways like that, and what might help them to make safer choices. So like I said, this work is ongoing, but to get this right, we started by digging into the evidence to contribute to, again, a kind of formative or baseline evaluation. So we did a lit review to understand the psychology behind risk-taking in groups of young people. And then we layered in the primary research, and that involved talking to Canal and River Trust staff who see the stuff firsthand, talking to water safety experts, and then most importantly, talking to young people themselves. And we were working with the Wigan Youth Zone. We actually co-designed the campaign idea with young people, and they helped shape the direction, especially a kind of focus on peer-to-peer influence, which became crucial. And the campaign name, Have You Got Their Back, which you can see there on the right, that actually came from something a young person said in one of those sessions. And we ended up piloting the campaign in Wigan, and we used some early materials just to see how well it would work before thinking about a wider rollout. And that's what I'd really call a developmental evaluation. So it's primarily qual, we got direct, honest feedback from young people. What they said was that the message was really landing, but the design was not really landing. And that's exactly why we carried out that evaluation, not kind of for the sake of it, the sake of just evaluating, but to learn what needed to change to inform future action. And I think visual communication is huge, particularly for this audience. And we often say, we can't afford to be politely ignored, particularly on safety issues. So we're currently working on elevating the look and feel of this ahead of the national rollout, and that's based on the feedback that we got in that developmental evaluation. And then finally, if I've still got you listening, we're going to go into representation. Representation is obviously really important, and we've got a good example in public health here, which is from a COVID-19 campaign that we developed with the London Borough of Barking and Dagenham. We then returned to the borough to deliver two campaigns, one that was focused on the COVID booster and one on MMR vaccination. And we're still working together. We're currently training community leaders to talk to people about vaccination, what it means to be vaccinated. So Barking and Dagenham, just as a bit of background, had a really low rate of COVID vaccination uptake. It's a very diverse borough. About a quarter of the borough identify as Muslim. There are big Eastern European populations. Just under a quarter of the borough identifies Black, and then a further quarter as Asian. So really diverse borough, there's a lot going on. The output of our first COVID campaign, you can see on the screen. So this was creative that really felt tailored to those specific communities in the visuals. And these are actually real people in the campaign that we spoke to who were really excited to then see themselves in the work. The messaging was tailored. Sometimes the language of the copy itself was also tailored. And this was really about giving people a reason to get the vaccine. We know from behavioural science that increases compliance and motivation. And these reasons really came from the community themselves. And you can see some of the reasons there. And there was a lot behind this. We interviewed leaders from community groups. We spoke to over 100 local residents. We spent a lot of time at a very sizable local mosque who are actually really brilliant. And then we carried out a lot of desk research into the barriers that might prevent some of these sort of underserved groups from getting vaccinated. And this approach, which really came from the communities themselves, went well, particularly the MMR work, where the bar actually broke the London record for the most vaccinations delivered at a single clinic. And this really showed the importance of fully engaging an audience with the work. And I think we're really proud of this work. And then I'm going to finally talk to you about a representation example from another international campaign. This is a safety campaign in Australia, which encourages safe driving. And there's a centralised English language campaign, you might have heard of it. There's a poster in the middle. The campaign is called Don't Let a Car Change Who You Are. It's really about kind of not being aggressive, particularly in the car. Nearly every asset in the campaign is available in Chinese, Vietnamese, Korean, Arabic, and these are really large communities in Australia. I looked it up, about 6% of people in Australia identify as Chinese, for example, so it's really important to be inclusive here. And there's also been an active effort to focus on Indigenous Australians. They over-index on KSIs or killed and seriously injured people in road traffic collisions. And you can see on the left here an example of celebrities and leaders with Indigenous heritage have kind of been called on to support the campaign, to spread the message to their own followers, particularly those who have lost a friend or relative in a road accident or collision. And having this level of representation, I think, really shows respect to the community. It shows a level of understanding, and most importantly, we see that it works. So I'm going to sum up before Tim starts playing the Oscars music, and I've got to get out. That was a real whistle-stop tour of the learnings from public health campaigns that we think could be echoed in safety initiatives, and have been in some cases. So I'm just going to pop this back on the screen with some further explanation. If anyone would like to do a quick screenshot, please feel free. We're also going to be sharing a recording of this event. I saw someone ask that in the chat. And I've quite audaciously also added a Claremont logo to the slide. Should you want to talk to us about your own safety problem, feel free. You can connect on LinkedIn and we can have a 15-minute chat about what your problem is and which of these things might be useful to you. So back to you in the studio, Tim. Thank you.
Studio being my bedroom in Essex, but thanks very much.
Studio in your closet office, yeah. Exactly.
In my closet office. Thank you, Mikaela. That was fantastic. It really was a whistle-stop tour. Was that 10 case studies in 15 minutes? Really appreciate it. We'll let you bounce off, and we're going to keep the pace up, and we're going to go straight through to our lovely panelists. So panelists, if you could show your faces back on camera. Here they come. Really grateful to our panelists today for sparing the time to take part in this event. So before we get into your questions, and please do use the Q&A function and the chat function to ask any questions that occur after Mikaela's presentation or our discussions over the next half an hour or so. Yeah, please do get those questions in. But we posed a question to our panelists ahead of today to reflect on a little bit, and we'll get their ideas about this question when we introduce each of them. The question was, which one principle or way of working in public health would you like to see more of in our work on safety? So we're going to get people's reflections as we go around. We're going to start with Paul Steinberg. Hi, Paul. Before joining the Road Safety Trust, you worked in public health campaigning brilliantly. So you've got an interesting and perhaps unique perspective on this. So what principle from public health would you like to see more of in safety?
Thank you very much, Tim. So I think my principle is around addressing root causes, not just symptoms, and what public health also calls upstream thinking. As you say, when I worked in HIV prevention, which was probably over a period of about 15 years or so, mostly in local government, as I can see some colleagues on here actually from my old days, which is nice. Hello, everybody. We didn't reduce transmission of STIs, or particularly of HIV, by simply telling people to be careful or to consider prevention methods in isolation. What we did was we made all sorts of efforts to tackle stigma around HIV in particular, and around same-sex relations as well, to tackle the system. And so we improved access to testing and treatment services. We changed the systems that left people feeling confused or vulnerable or isolated or even uneducated about their prevention options in the first place. So what we looked at essentially was both behaviour and the environment, creating the conditions where safer choices were supported by policy, infrastructure, access, but also culture. And I can talk probably a bit more about that on the bars, pubs, clubs, you know, the real coalface a bit later maybe. And in road safety, as I've learned over the last year, that mindset is exactly what's referred to in what we call the safe system, which accepts that people make mistakes because we're human. And instead of blaming individuals, it's meant to design systems so that those mistakes don't result in death or serious injury. So just very briefly, that's safe roads. So you could think about lighting or potholes, example. Safe speeds, that's about the enforcement of speed limits and about driving at the correct speed in the right areas. Safe vehicles, which makes sense, from tyres to pressure to depth. Safe road users, so the people who are on the vehicles or using the vehicles, and then post-crash care. And I think the thing that has struck me in the last year is that from being, rather than shifting from going from a reactive blaming to designing systems which actually support positive choices and safer systems, I'm quite struck by how many road safety professionals and actually how many public health specialists don't regard each other as natural colleagues or as sort of working in the same industry, if you like, and yet they really are. And so really, if I had to champion one principle, it would be this: go upstream, build safe systems, and use the full weight of public health thinking to challenge how we save lives on our roads.
Thanks, Paul. It's brilliant. Hopefully this event will smash those two, well, that's probably the wrong choice of words, bring those two worlds together a bit more effectively. Thanks, Paul. We're going to pass to Jill Nash from University of Bournemouth. So Jill, you've worked extensively in water safety over the last few years, as well as public health, as well, issues like smoking. So what's your take on this question?
Okay, I've been around the houses a little bit with this one, and there's so much to choose from. I will be a little bit greedy, I'm afraid, and say a bit of F and a bit of E. So forming partnerships for better evaluation would be my kind of key principle. And the reason I say that is because forming partnerships for collective impact should be informed from collective data sharing. So what I can certainly see in, this space is that there is a lack of centralized strategy for all types of safety because there's no kind of overarching cross-sector national safety framework. So this means that the data sharing and evaluation is therefore quite limited. So unlike public health, where data and outcomes are very, very closely monitored and shared, data safety data rather, is quite siloed between the different services. So we've got the NHS, we've got the police, we've got the Coast Guard, we've all got lots of lovely bits of data. But of course, what this does is it really limits our insights into the broader patterns and obviously those effective interventions that could possibly take place. So, for example, if I look at the WADE database, that's the Water Incident Database, it tells me about the fatalities of drowning in the UK. But what we can't see from that, or what rather isn't clear, is on a national level, the rescues or the incidences or the near situations that might have required an intervention. And that might not necessarily be a call out from the services, but a friend going in to rescue a mate. So what I would like to see better of is kind of understanding incidents that happen, and particularly around the water, but actually on a shared system, so we can actually pick out these risk areas that we can then set out those interventions. So because this information is a little bit hidden, it's beneath the services, it's there somewhere, but we can't see the data. Obviously, then we can't see these patterns. We can't track what's working or what could work and why. So for me, in short, UK is amazing for regionalised safety initiatives. It's absolutely fantastic. But bringing them together into a cohesive, collaborative system would really amplify their impact.
Thanks, Jill. Appreciate it. And I think that leads quite nicely into Tori, if we can come to you next. So you've led a lot of research and evaluation in policing, social services, education. So what principle would you like to see better represented in safety?
Thank you ever so much. I would say actually testing the things that we do to see whether they work in the first place, because I think people are often scared of running experiments and of trying things and testing things and trying to get results. And I think that fear often comes because they try to do it afterwards, which leads to some poor academic having to go back and try and piece together the things that have already happened and they can't change it, as opposed to moving it upstream and starting with it. And I think we wouldn't give our children an untested drug, yet if we want to prevent them carrying knives, we'll happily throw money at whatever our idea is that we think is the right thing to do in that moment. So I would like to see us treating it like medicine. we are treating a problem, we are treating harm to human beings, same as on the road, same as in the water. I want to see us experimenting and testing best current evidence against the new thing that we want to do to prevent harm.
Thanks, Tori. Brilliant. Simon, we're going to come to you next. So, Simon, you've worked on behavioural change research for a long time, contributing to all sorts of policy areas, including road safety. I know that. And what's your answer to this question?
Well, I'm tempted to now. Everyone's made such good points. I want to agree with everyone else. However, I'll stick to my original thought. So, obviously, as a researcher, obviously I was drawn to evidence. I'm particularly interested in the value of qualitative insights into people's perspectives and perceptions. So how do people experience the world? How do they make sense of it and find value in it? So some people may be thinking, okay, that's the problem with qualitative evidence, though, it's just perception, and it's true. Very struck by what Tori was saying there. Perceptions can be wrong. If I ask a room full of people what will change their behaviour, I can tell you now some of them are going to tell me they need to be scared or shocked. It's a very common perception, and it's usually wrong. So if our question is what works, asking people what they think would work is of questionable value. I'd definitely go with what Tori was saying. But if we go to another question, say what is really going on here, which is, of course, the question behind the A, address root causes. And when we look at that question, then I'd say, well, perceptions are part of those root causes. Maybe it is just perception, but it's still part of the system in which my behaviour arises. How safe I feel, for example, plays a causal role in my behaviour. Feelings are facts. It is a fact that I have them, and that makes a difference to what I do. So then I thought, well, that means if we're going to do S, take a system-wide approach, we need to recognise that the perspectives of agents in that system are part of the system and gather evidence on them. And then I thought, well, we probably want those agents to do something different as well. And that means, well, that could mean changing their perspective, or as that's usually quite hard, we might decide we want to change what we say and do to accommodate their perspective. Either way, evidence of other people's perspective is the first step to doing F, forming partnerships with these key agents. And then I thought, well, of course, perspective is also something that differs between people. So, for example, as a result of cultural differences. So if we want to do R, representation, evidence of differing perspectives and perceptions is a starting point. So after all that, I'm afraid I ended up adding a principle. It's a silent P. It comes before the S, like in Psalm, and it's P for people's perspectives and perceptions. We need to recognise them as causal factors in both problems and solutions.
Brilliant, Simon. You're scoring very highly to cover every letter, and then add an additional letter as well. It's brilliant value. Thanks so much, Simon. And Ben, we'll come to you. You've led or collaborated very heavily on a huge amount of our safety work here at Claremont over the years. So what's your take on this question?
I observe that with public health, it covers so many different things. It covers a vast area, and you would have thought that it would turn into a big kind of blob, actually, but it doesn't. And the professionals that work in public health are much better, it seems to me, at working together across all these different issues than they are within the safety world, certainly from a communications perspective that I come from. And I'll illustrate that. I recently submitted some stuff to the World Social Marketing Conference and a couple of abstracts, both safety abstracts. And there was no category for safety for me to enter. I had to wedge them into health. The academic courses as well, one of my favourite courses is the UCL Behaviour Change Department. They don't focus on safety. They have health and sustainability as focuses. And if I look at the agency world, the communications agency world, of which Claremont is just one small player within the whole world, there is, to my knowledge, there is not one specialist safety communications agency working in the UK. There are some that dabble in it and do bits of it, but there isn't one. So I think it's underdeveloped. I think that we're not working together properly as a professional community as well as we should be. So my desire and dream is that we learn from public health and become a better community of professionals working together.
Thank you very much, Ben. So we're going to go into further questions now, and if you have any in the audience, please do use the chat function, the Q&A function. But let's talk a bit about risk to kick this off. So one area where public health is focused incredibly successfully, obviously, is on on risk and understanding attitudes to health risks, cigarette smoking and drug taking and sexual behaviours. So how does the concept of risk taking and risk transfer to the world of safety? Simon, I know you had some thoughts on this.
Yeah, I mean, I just think building a little bit on what Ben was saying there about safety as a context. One of the things, if we're coming at things from a safety perspective, I think we associate the word risk then with safety. We think about safety risks, and it can kind of lead you into a mindset where you're trying to appeal to people's kind of inner actuary. I mean, we just need to have the safety risks and to do that calculation. I think risk is a much bigger concept for as an ordinary human being in your everyday life. You're considering many risks and rewards that are not to do with safety. A really simple example is if I were a much younger man and I were out in my car, then yes, there are the risks that might be associated, safety risks that might be associated with the certain behaviors, but there are also then going to be risks to, say, my social standings standing with my mates in the car, which might be much more salient and much more present. Turning into a grown-up person, something I think we see quite often is there are risks towards my perceived risks, my feelings of risk around, will I get there on time if I'm, say, a delivery driver, something like that. So we need a much broader concept of risk, I think, that goes beyond safety risks, if we're seeing it from the perspective of the people we're trying to influence.
Thanks, Simon. Ben, did you have a take on this as well?
One observation is that in the safety world, where I think we've been able to do our best work is when we've had a client, a senior client, who comes at it from a starting point of, we need to do something new and different because what has happened up to now hasn't worked. And when they have that mindset, as we've seen with some of the senior police officers that we've worked with, is when we've been able to really get under the skin of some of the things that Simon just mentioned about why people are drawn to risk-taking activities, and we're able to address them. If the client is not willing to open up to newness, we can't go there, and they will often try to talk to people who do risky things in the same way that they talk to people who are more risk averse. So I think there's a lot about openness to newness that comes into play.
Okay, can't we just come and just shock them into conformity? We need to address shock and kind of shame-based approaches, don't we? It's already come up this morning. We know these have a big impact on emotion when people see these campaigns, but it's not necessarily following through on behaviour. Why isn't a shock campaign enough? Paul, I might come to you on this one actually.
Yeah, I mean, the evidence is, I think that the effectiveness of shock from fear-based campaigns is very mixed. And really, I think the research suggests that if you take a fear-based or a shocking approach without accompanying supportive measures, such as education, enforcement, access to the services that allow you to do the behaviour that you are trying, the optimal behaviour, that actually it doesn't lead to sustained behaviour change. And actually it can cause desensitization, avoidance. It can actively undermine the message that you're giving. In the history of HIV, in 1987, the first Don't Die of Ignorance campaign, which many of you probably remember, and which I've given far too many lectures on over the years, people remember it, but they remember it for the wrong reasons. But I guess at the time it was seen to be effective because HIV and AIDS was such a scary unknown virus, and so shocking people, it did actually have a very obvious effect on sexual behavior, and other STIs went down. But if you all cast your minds back to not that long ago, 2021, I remember walking through the streets of central Manchester, which were pretty deserted, and seeing those very shocking campaigns which said, look her in the eyes and say that you're obeying the rules. And they had a desensitizing effect on people, but they also led, I think, to the lockdown backlash. They didn't help us sustain the behaviours which were about wearing masks and getting vaccinated. I think the other thing that we saw, and I'm sure colleagues will come in on this, is that the evidence of the academic studies around fear-based campaigns is that for many people, when you talk to people, they think that fear-based campaigns are good for the other, because I know the information, don't I? I know how to behave well, but those younger feckless people, they don't know how to do it. So let's scare them into behaving well. And I think if you look at the evidence, and I'm not an academic researcher, but I've read it, it just suggests that actually it doesn't work in a sustainable way. And so when I ran HIV campaigns in London for 7 or 8 years, we opted for a positive and proactive combination prevention approach, which looked at the proactive things, the things that you could do to prevent yourself from getting HIV and your partners. And I think that's the approach that we need to take.
Thanks, Paul. I'll tell you who is an academic researcher. That's Jill Nash. So, Jill, you've done some really forensic stuff around, responses to shock campaigns, haven't you?
Yeah, absolutely. I would agree in part, Paul. It's very mixed bag of academic studies on this space. My kind of interest is looking at how emotions in general, how we respond in general to campaigns, and not just, using fear, but also things like guilt and humour and other kinds of levels of valence of emotions, and whether they cast out, from the emotional spikes that we experience, is whether they then develop further in terms of a longer lasting, behavioural change. And a study that we've finished wrapping up for the RNLI was looking at particularly young men's responses to water safety ads content, and we measured their facial muscle movements in using smart glasses. So we were measuring emotional arousal and valence in the moment, and then what we did is we followed that up with long-term studies, so following those participants through 3 and 6 and 12-month intervals. So we did a bit of qual and we did a bit of quant. And what was really interesting is, as we know, emotional spikes don't always guarantee behaviour change. But what was interesting for this particular study is those ads that carried very, very high levels of emotional intensity, and unfortunately they were the fear ones, they were the shock ones, those messages did have more longer lasting effects in terms of being remembered, being recalled. And I do think that was partly because of the relevance, because of the repetition, because of reflection and all of those lovely stuff. But so it wasn't just a reaction to the ad. Those ads, the messages did carry through beyond, the experiment. But again, there isn't really solid, this is just one study, and this isn't, I wouldn't suggest that we use this study to, design our campaigns against. But what I did find was interesting is that we did notice that fear did hold strong in the moment and beyond. But I do believe that it is a lot more complex than that. I think it is, it is also other factors going into that, like, the reflection, the relevance as well, particularly for this audience. And as we were dealing with quite high risk takers, we were dealing with kind of looking at specifically young men, and we found that, perhaps the softer landing campaigns just did not work as well, particularly for this demographic. I'm still not quite sure yet why, and we're still digging into the findings on that. But I wouldn't say that shock campaigns, are enough, but I don't think that they should be ignored.
Interesting. By the way, panelists, if anyone wants to come in on any of these things, there's an interesting discussion going on here. You can reflect on that maybe, but Jill, the studies that you're doing are really amazing and comprehensive, but we're kind of getting into the world of evaluation a bit, really trying to work out whether what we're doing is working and having the impact that we want it to be. And I think the evaluation can sometimes be a bit overlooked, or perhaps underfunded, perhaps in the mix of overall project funding, for wanting to get interventions into the world, get stuff out there, try and get something moving. So what's the case for making sure evaluation gets a fair look, whatever the budget? Tori, what are your thoughts on this?
Thank you. I don't think it has to be expensive. I think often if you go to an academic institution after the fact and ask them to do something, it's hard work. It's a lot of work to then do that, as opposed to if they're involved up front, excited about the project, being able to help define the two things they want to measure between. I think the tricky bit is if we want to know whether something worked, and then if we want to know whether it was good value for money, especially, we need to know what would have happened to a similar group if they hadn't had the thing we gave them. So if we were doing it on the roads, we need to take stretches of roads where we change the speed limit down by 10 miles an hour and stretches where we change it down by 20 and compare the two. It's a very oversimplified idea. Or a stretch of the waterways where we put up our messaging and stretches of the waterways where we don't, or where we put different messaging up, to test whether there's a difference between them. But we also need to do some really good upfront planning around how big an effect are we likely to see. So how many cases are we going to need in order to see it? How prevalent is the bad stuff? Because I've seen, sadly, interventions where, one example is where they wanted to deliver an intervention for women in custody. And so they employed somebody full-time in a custody block to work with women who'd come into custody. And then a few months later were sort of puzzled why they'd only seen 4 or 5 people going through the treatment. They hadn't done their data work up front. They hadn't planned it. And so that snap decision to put an implementation in, actually, I'm not even talking about evaluation sometimes. It won't be implemented well. It won't be delivered well. It won't be tracked well to see whether we actually did it. And at the end of it, we won't get a result to say, did this work better than that? And that's what I think we need. And it doesn't have to be difficult, but it does have to be thought through up front. There is usually a way where every stakeholder in the room can get something that will result in some evidence that won't be a perfect trial. And I don't believe in running perfect trials that can only work in lab conditions, because you can't actually implement them afterwards. It's about the best test we can do of what we can actually deliver.
Thanks, Tori. Appreciate that. We're going to zoom out a little bit now. Ben, I've got a question for you because it's about the field in general. So we've got a question here from Wayne Mackay. Thanks, Wayne. What's your advice for demonstrating the value of behavioural science internally, particularly when there's no dedicated team or resource, so it's seen as worth investing in and not just a nice to have?
I don't have a soundbite answer to this one, I'm afraid. I think sometimes we have to just emphasize or communicate what's the alternative to taking a behavioral science approach. What is a behavioral science approach? It's a rigorous approach where you do some of the things that Tori was talking about upfront design work and scoping, where you adopt some of the public health principles of bringing multi parties in rather than it just being siloed off in one part of the organisation. And by saying, if we don't do this approach, if we don't take a behavioural science approach, what is the alternative? I feel that I've observed over the last few years is some people have willingly gone into a rigorous, more rigorous behavioural science informed approach and run towards it, and others have kind of been dragged kicking and screaming into it. But one way or the other, we're all going there, because I think the field in general is maturing and kind of getting itself together on these things. That's a bit of a woolly answer, but I hope it's given something about just bringing people in and explaining that this is not new. This is just a commitment to doing it properly and rigorously. I think people don't like to do new things. They prefer to do stuff that feel like they've already been doing them, but we're just taking them up a peg or two.
Thanks, Ben. Appreciate it. I'm going to go back to one of the points that Mikaela was making in her presentation about, designing for in inclusive ways and thinking about particular audiences whose behaviour we're trying to change. I think it's a pretty rare case that a safety campaign is designed with the entire population in mind. I suppose COVID and those sorts of things are the exception. But what are some good examples of campaigns that have worked for really specific audiences for greater impact? Jill, have you got any thoughts on this one?
Well, I think I have to mention the RNLI Proud National campaign here, because I think, we had a conversation about this before the webinar, and, broad, big national campaigns for safety there aren't so many of them, that I can think of which would be better than this one. But the Joint National Campaign, RNLI's National Water Safety Forum, Respect the Water, obviously it was aimed at, advising, anyone who's relevant finds themselves into difficulty can heed the advice. But there was some very, very squarely, nicely kind of pointed pieces, particularly the adult men, who we know are the highest risk groups. And what they did is they did some great execution things. There were some good real life stories. There were the practical advice tips for the flow to live. And of course, they delivered some really nice media that was really squarely skewed at this age group. So sports, TV, pub activations, they did outdoor stuff. And as well, we saw that there was lots of evaluation. We can see that there were loads of survival stories from that. So I think really for me, the best example that I can think of that's worked on a national level, but has also been very specific for those particular audiences, is this campaign.
Thanks, Jill. Paul, do you have any thoughts on this one?
I mean, I think that there's a general principle here, which is that public health and campaigns, when they're done wrong, or when they're done sort of half-heartedly, or maybe partially due to funding or whatever it is, relies too much on a sort of blanket approach, a mass media approach. And if I speak about what we did with Do It London and the London HIV prevention programme back in the day, what everybody saw, if you lived in Greater London, you saw the same advert, you saw the same information, which was about essentially the 4 proven ways to prevent HIV. And that went across billboards, bus stops, tubes, so everybody got the same message. Part of that was a deliberate attempt to destigmatize the subject and to show that it wasn't something that only affected particularly gay, bisexual men and Black African communities. But having said that, the epidemiology showed that those 2 communities were the most affected. And so we had to develop a way of making sure that while we had a sort of generalist campaign with wider public awareness, we also targeted and tailored. And I think the most important thing is to do that through channel, and also to do that through developing it through co-production and through the early stages of how you produce your campaign. One of the things that we were both criticised and lauded for in the Do It London campaign was that we didn't use faces on our campaign. It was an entirely sort of graphic campaign. That was because we did a lot of research in the early days, which said that for years and years, many of the communities most at risk had been targeted by an image purportedly representing them. So, a purportedly gay man on a campaign, which made it feel that they were both being sort of publicly focused on and shamed, but also it meant that everybody else switched off. And we knew from the data that there was a rise in HIV in over 50 heterosexuals post-divorce. So we had to attempt to make a way to be both targeted and inclusive at the same time. And that's probably where also partnerships come into, and Jill's just mentioned about activations through bars and clubs. It's not just about what people see, whether it's on a billboard or on Facebook or on TikTok, and we can probably talk a bit more about that as well. So I think the targeting, the tailoring, the general population versus the at-risk communities, it's an art as much as it is a science, really, and it's also about your budgets and where you get to spend the money in the different channels.
Thanks, Paul. Tori, I want to come back to you and pick up from a point again from Mikaela's presentation. We're in this sort of slightly ironic situation that we're trying to measure things that aren't happening. That's the success of a safety campaign, that the harm we're trying to prevent doesn't happen. So how can we measure things that don't actually happen? And sometimes we're waiting for, Jill mentioned the Wade water statistics, which are published annually, but can sometimes be quite a long lag until you can see what's actually happening in the community whose safety you're trying to protect. So how can we measure things that don't happen, and what kind of proxies can we use to show success in the shorter term?
Of course, thank you. I think saying that it won't happen at all assumes that our interventions are going to work perfectly. And we currently have very little information about, especially in crime and criminal justice. So prevention of crime probably has 1,000 randomized trials in total that have ever been done. I think there's about 40,000 that are done in medicine every year. Across wider safety, probably even fewer than there are in crime. And So if we don't have any tested things to compare to, we've got to check whether what we're doing is better than the status quo. So we have to find a cohort that has enough of the bad thing we're trying to prevent. And it might be that we look at upstream harms that may lead to the outcome as our measurements so that we can pick it up more. Or sadly, in some things, we do have enough cases of it going wrong. We do have enough cases of children using knives on each other. We definitely have enough cases of road traffic collisions. And so if we do have enough and we're able to test one thing against another, and we do it on a wide enough scale, we should see a difference between those things. We just need to plan it up front to know what our likely outcome is.
Thanks, Tori. There's a little box that pop up that tell me we've only got 5 minutes left in our session. So we're going to do one last question and try and get a word from each of our panelists. And it's been hinted at with questions we've dealt with already this morning, but budgets are almost always a constraint, sadly. So how can cash-strapped safety leaders adopt some of those safer principles that Mikaela talked us through without breaking the bank? So that's your challenge, panelist. Simon, what's your answer to this?
There's a lot to say here. I think I'm going to link it back to there's been a lot of conversation in the chat about the fear and shock topic, which I think has been really interesting. And one of the points that was raised at the beginning by Ruth, hello Ruth, was about the fact saying, should we review it's discouraged? I think one of the way I'd put it is to say that if we look at the history of road safety, what's discouraged is unthinkingly saying we just need to shock people. What we really need is a clear theory of change for any intervention, which is an understanding of how do we think what we're going to do is going to bring about an effect. So I would say, rather than say how to save money, I would say the one thing you cannot not do is have that theory of change. Now, if fear, emotion is part of that, you need a clear story about how that is going to feed through in the context of other elements of that intervention to a consequence. If you don't have the evidence for the theory of change, you need to gather the evidence. All interventions need to either be evidence-based or evidence gathering. You can do one or the other, but there's got to be that element. So don't skimp on that. Sorry, it's a roundabout way of doing it, but quick response.
Thank you. Nicely handled. Paul, what's your take on this?
I would echo what Simon says, and I think the other thing to say is that I used to teach the master's course in public health around social marketing, and the principle around social marketing is there's a lot of people, maybe politicians who are in a hurry, see a problem and they decide that we need a campaign. And actually, the theory of social marketing is that actually you don't necessarily land and end up with a big mass media expensive billboard campaign. You might be able to spend 4 or 5 figures on we have media all around us, social media, advertising campaign, Instagram, TikTok. So you don't always have to reach for the most expensive, shiny approach, but you might not even need to have a media intervention. You might need other interventions. But I'll just say, Tim, if I can, while I've got my little spotlight, Carla Lowe's asked a question, and I've just seen the Q&A about NHS data and public health data. I just wanted to point to, because I'd be remiss if I didn't. So the Road Safety Trust just announced just before Christmas £400,000 worth of funding for the University of Southampton NHS Trust with TRL, and that is looking, I think it's called Data Saves Lives, and you can find out more about it on the Road Safety Trust. It's I think a groundbreaking linkage between healthcare data and road safety data. That's very difficult to do, as you know, because of the strictures around NHS data, but we have managed to fund a project which is doing that very thing. So Carla, if you look on our website, you'll be able to find more information.
Thanks, Paul. Do feel free to drop a link in the chat so people can connect to that. That's great. We are rapidly running out. Jill, I'm going to give you a take on this. How can we do these sorts of methods and not break the bank?
So tough, isn't it? My top tip would be work with universities, wherever you are, whether it's research, whether it's designing something, whether it's campaign support, co-produce, share costs, lean on the expertise from communities, and using universities is a great resource for that. And that would be my one tip, really.
Thanks, Jill. Tori, your take?
I'd say if we do it well, it makes it cheaper. So by doing the one thing that works best, we don't spend on the 6 things we're doing that don't work as well. And it's really nice to see when trials come out showing no effect. We spent quite a lot of money on a custody coaches program in Thames Valley, and we thought it would work by a reachable, teachable moment of them being in custody and making referrals. It had no impact whatsoever. But picking people who had a much higher impact and giving them a year's worth of mentoring and support reduced their knife carrying by 60%. So it is possible to do really well if we plan, and it's much, much cheaper to not waste the money on things that don't work.
Thanks, Tori. Brilliant. I'm contractually obliged to give our founder, Ben, Casper's last word today.
I would say invest in scoping before you plunge in. I think Tori's alluded to this a lot. What was that adage, Tim? If you have 5 hours to chop down a forest, spend 4.5 sharpening the knife and checking you're in the right forest. I think I have some regret with my career that I didn't do that more earlier on. I just plunged in and did what I was kind of told. Now my advice would be, for saving money, is sharpen your axe before you get started.
I'm glad you remember axe and not knife. That could have been your problem in the first place. But right, okay, it is 10:30, so we need to leave it there. Thank you very much. Can I please thank our panelists, Paul, Simon, thank you, Ben, Tori, Jill and Mikaela for presenting. Before you go, please do follow us on LinkedIn for all our news and events. You might see, as I'm talking, our poll popping up on screen. It takes 2 minutes. Please give us a star rating, TripAdvisor style. There's a couple of opportunities to comment so we can improve these sessions in future. I think that's everything in terms of admin. Thanks for supporting this event, and we'll see you at the next one. The poll will be live after the event finishes as well. Have a good day, everyone. See you next time. Thank you.